Okay, 15 minutes.
Hello, my name is Philip Johnson. I'm a graduate student at West Texas A&M University, and this is my project for the semester. I did rapid medical examinations. There was, down in the ER, we started doing rapid medical examinations as opposed to the old method. I'm going to discuss what we did, some of the changes, kind of what all is involved with that. But my project, I was part of I participated, I helped with the planning, the implementation, and some of the evaluation. The theories I used for this project, there's transition theory. Part of that theory was talking about how patients often feel like when they go to the ER, they transition from regular person, sick person, to a patient as a part of their stay. Like when they come in the door, they're just somebody looking for assistance, help, and as they get a hospital bed, they transition from just being somebody seeking help to a patient. And so RME would actually take that make it a different transition where they don't actually transition to being a full-blown patient by being in a hospital bed. They just get the help they need and get out. Then there's PDSA model. That's the Plan, Do, Study, Act. Let's see. The plan is to implement RME, rapid medical exams, for many patients who would normally go to lower acuity sections. During busy times, this will further speed the process for the patients that will discharge home, and also speed the process for patients that will require hospital admission. D is for do. It's the utilization of the RME process. Study, looking at how long patients are in the ED from time of initial triage, whether RME makes the waiting room less crowded, and asking nurses if they feel the process improves their satisfaction with the job. The study also involves looking at what goes well and what does not. ACT would be looking at what goes well, what makes the patient experience more efficient, and what gives the nurses the greatest amount of satisfaction. And then if there's any information that conflicts, we can go back to the S of study and make determinations from there. Now, in order to understand RME process, it's important to understand how we triage patients, and that's the ESI scale. ESI 5 is somebody who comes in and maybe they just need a med refill, or they need sutures removed, or a simple test that does not require lab testing. ESI 5 is pretty much somebody who really isn't sick. They can be sick, but they just don't require any tests. ESI 4 is somebody who, we get a lot of ESI 4s. Maybe it's a child with a fever who doesn't actually have a fever anymore, or somebody with a cough, or somebody who just recently started vomiting, and they need one test. Could be blood work, could be a chest x-ray. They just get one test, and then the doctors can make their determinations from there. That's an ESI 4. Now, ESI 3 is somebody who needs 2 or more tests. So somebody who comes in with abdominal pain, they might need blood work, chest x-ray, or an abdominal CT, or all the above. I mean, it could be 10 tests, it could be 2 tests, but it has to be 2 or more. they would be an ESI 3. ESI 2 is somebody who requires lots of tests, and there's the possibility of imminent harm if we do not act. Now, there's not a guarantee of imminent harm if we do not act, but it's just a possibility, like suicidal patients, or pretty much most psych afflictions are 2s, or if there's threatened loss of limb, if they have compartment syndrome, and they could possibly lose a limb, they would be a 2. And then ESI 1 is, there is almost guaranteed imminent harm or death if we do not act. Somebody who's having a ST elevation MI, STEMI, stroke, active stroke. Somebody's unconscious and unresponsive, somebody who's being actively coded, they would be a 1. So 1 is our most acute patients. So the reason I told you all that is because Army kind of makes it does its business in the 3s, between 5 and 3. There's hard and soft levels. There's some chest pain people who come in who are, they have heart history, and they're gonna need some labs, so usually they'd be a 2, but a soft, that would be a hard 2. Whereas a soft 3 is somebody who has chest pain, who's gonna need all those labs, but they don't have any heart history, so they're not necessarily a 2. They would be a 3, and we can send them to Army because they just need the labs. They don't necessarily they're not in threat of imminent harm. There's all kinds of scenarios, variations to look at. The way we used to do it is we had the orange pod downstairs. And thank you. So we had these 2 rooms on the entry. We had 5 rooms down here, and then we had this is room 8. Then we had 1, 2, 3, 4, 5, 6, and 7. So the way we used to do it, there would be 2 nurses in this pod, and this one room is emptied. They would discharge the patient, and then they'd put somebody in the room. The nurse would go continue the triage, and they just funneled in and out of the rooms individually. The change that RME brings about is they all funnel through rooms 1 and 2. So they come into 1 or 2, and these rooms have just chairs. These 6 rooms have beds. Well, what we were doing was we took all the beds out of 8, put chairs, put a Nintendo Wii, and they would come in through 1 or 2. They would get their initial lab tests, whatever was going to be ordered, chest x-ray, blood work, flu swabs, it's the season for that. They'd come in, they'd get their initial tests in 1 or 2, and then they would either go to 8 to wait for their results, or they could go back up to the waiting room. And then they had 2 nurses that were, they had 2 nurses for Army, and then they had 1 nurse that kind of floated around and made sure, checked on the needs of the patients elsewhere on the unit. This speeds the process because they can put a whole bunch of people, they can take a whole bunch of people, do their tests, funnel them all to room 8 or the waiting room, and And so you can have like maybe a dozen people, whereas before, you topped out at 8. 1, 2, 3, 4, 5, 6, 7, 8. So during busy times, that would enable you to actually get more people in and out. That's the bed was removed from room 8. 6, so they actually had 5 beds and 3 chairs. So the goal of Army, the rapid medical examination, improve efficiency of the care provided, improve patient satisfaction because they're getting in and out faster, improve employee satisfaction because they're not looking at the waiting room and seeing, oh, there's still 5 patients that we can't see right now because we don't have discharges for these other 8 patients. And then decrease door-to-room times. We can pretty much as soon as they come in, we can say hey, and then immediately get them into RME and get them out faster. And I had no patients like that. But I had some learning objectives this semester. Use leadership skills to teach, coach, and mentor other members of the healthcare team. I did a lot of research on RME during this project. It assisted in a better rationalization and justification of the implementation beyond the topics that were discussed in process improvement team meetings. The process improvement team meetings were great. They looked at the primary rationale of decreased wait times for patients and improved throughput for staff. But I felt like I could more easily discuss issues with a lot of the staff because I was still a staff member. I was not designated as a leader. I'm not administration or anything like that. I'm just another one of the people working on the floor. So I could just walk up and say, hey, how do you like RME? How's it treating you? And I felt like that actually gave me a better rapport with my fellow nurses than I might have had if I was in administration. Next was integrate clinical prevention and population health concepts in the development of culturally relevant health education, communication, care strategies, policy development, and interventions. There are several parents that bring their young child to the ED every night, and usually it's for a fever. And sometimes the child doesn't even have a fever when they're checked in. So it's important to be able to educate those patients as, hey, take your kid, give them some ibuprofen, give them some Tylenol, alternate every few hours, go between those two. You can bring down the fever on your own. A lot of them said they don't even know the dosage, so we can educate them on that. But continued education of patients, even though it's a faster process, that can improve the patient satisfaction as well. But that was part of the clinical prevention portion. Let's see, we've got advocate for the value and role of the professional nurse as a member and leader of the interprofessional healthcare team. The professional nurse is on the front line of patient care and an active member of the healthcare team in the direct provision of care. It's not so obvious the role the professional nurse plays in improving throughput, and it becomes very evident when a less experienced nurse is assigned to RME as opposed to a seasoned nurse. The professional nurse is a member in their contribution to the overall RME process and can be a leader when it comes to making recommendations as to improvements and improvement of processes. Nurses make or break the overall RME process. Let's see. And then analyze and use current and emerging technologies to support safe and effective evidence-based practice environments, cost effectiveness, and lifelong learning. So when I was looking at Cerner, it's no different from Cerner we've always used. They didn't make any adaptations for Army. So I spent a couple days with the informatics team, which is my what my master's is going to be in anyway.
What is it?
Informatics. From what I understand, it's a combination of the word information and clinics. So it's the computer nerds of nursing. But I looked at them or I talked with them and I said, you know, what kind of changes can we make? How can we improve the Army process? And they said there's limitless options if you can get it through, but ultimately they don't make the program, they don't alter the program, they just make the recommendations. So I can pretty much recommend whatever I want. It doesn't mean it's going to get through. I mean, that's how utilizing technology. So. But significant moment, the realization that RME is very effective at treating large numbers of patients efficiently. And I kind of wondered, why didn't we implement this sooner? From what I understand, it's been implemented before, and it receives a lot of pushback, and people just don't like it. And after talking to many of the nurses downstairs, they don't like it right now. They think it's cumbersome, it's a nuisance. They just straight up don't like it. And I've relayed this back to the process improvement team, and they've started rotating more nurses through Army than before. Before it was just the people who worked 11 to 11. So now they'll cycle some people in from the 7 a.m. shift, they'll cycle some people in from the 3 p.m. shift, just to give people a break, because once Army started, those 11 to 11 nurses were pretty much there every day, and a lot of them said, you know, if I have to keep doing this every day, I'm gonna burn out. I mean, they were just straight up about that. So ultimately, of my 3 goals the goals that I stated before, it was improvement of patient satisfaction, employee satisfaction, nurse satisfaction, and mid-level satisfaction, the nurse practitioners. The nurse practitioners, it makes a big workload for them. The nurses didn't really like it because they felt like the ones who were in there were there all the time. So it's kind of low there. The patients seem to like it. They're in and out faster. It's almost like a clinic more than it is coming to the hospital. The throughput times, it's really not improved, but it's not an accurate measure because they don't have a separate clock for the ones who come in and do Army and the ones who come and go into the back. So whenever we get bed holds all night long, that goes into the time. So there wasn't an accurate way to judge whether or not there were decreased patient wait times. So ultimately, it's just a learning process, and we're adapting and making changes. Hopefully, in time, everybody sees it as a benefit to the ER. Thank you. Any questions?
In the future, could RME, in the event that Northwest is able to get a clinic on site, could this process be used to take those non-emergency room necessary patients to ultimately ship them off to the clinic as other facilities have used? Would that be a good goal for RME in the future?
I think that would be a good goal for Army in the future. Just taking that process and applying it to other areas yeah, I definitely think it could be a possibility. I'll have to take that up with the Process Improvement Committee. Any other questions? Well, thank you for your time and your attention.
Good job.
Good job.
Was it 15 minutes?
Oh yeah, I think it was like